Hi, this is Andrea Kane, and I am here with HIT 352 Health Information Systems. We are now on week 8, and we are talking about computers in the health information management field, department, whichever way you want to look at it. So, if you are looking at your book, this is chapter 6. If you are looking at your syllabus, we are still on course objectives 8.2, 8.3, 8.4, which include learning objectives 9.2.1 through 9.2.7, 9.3.1 through 9.3.3, and 9.4.1 through 9.4.7. And keep those in mind because we will be doing those right on, it looks like, through week 12. We'll be focusing on those. So just something to keep in mind. Let's move forward and talk about those computers in HIM. Our learning objectives from the book are to talk about the systems that are needed to support efficient operations in an HIM department, to talk about the differences between various software products, and to improve the quality of data within HIM systems. Health informatics. Health informatics is the scientific discipline that's concerned with cognitive, information processing, and communication tasks of healthcare practice, education, and research, including information science and technology to support these tasks. This is a very important definition, and I would strongly suggest that you impress this upon your memory. And if you have to write it down several times or you have to do something to try and remember it, please do that because you will need to know this definition far beyond school, although you will definitely need it for the RHIT certification exam. So now is a good time to start pressing this into your memory. Computers in HIM, well, they are, as you would imagine, for pretty much every function in an HIM department. There's release of information, which usually has a disclosure management piece to it, encoder and grouper system, for those that are in the inpatient world, cancer, and other registry systems. Yes, before I do that, let me run back to encoder and grouper systems. Encoders are used not only on the inpatient side, but also on the outpatient side, where we see the most uses on the inpatient side because of the MSDRGs. However, APCs, sorry, getting my letters mixed up there, APCs are also a type of grouper on the outpatient side in a hospital setting. So you'll want to keep that in mind. Moving on to other registry systems, there's cancer, there's implant, there's transplant, there's trauma, and birth certificate registry systems. So there's tons of those. They may not all be in HIM, they may none be in HIM. I don't know, it will depend on the organization that you work for and how they have things divvied up, but it's important for you to know that those registry systems exist and what they do. If there is any microfilm or paper left that has to be physically located, there may be a chart locator system. Most hospitals and organizations have been on electronic records long enough that the only time they use a chart locator system is if they're going back 10, 15 plus years to locate physical records. And then I talked about birth certificates. Chart deficiency systems. Yes, there are still deficiencies to analyze even in an electronic world, and so there is always a deficiency system. Some places still provide transcription services, and some of those are in-house versus outsourced, but we still in the HIM field need to know about transcription systems, even though they are becoming rarer and rarer, especially on an in-house setting. Healthcare quality indicator system. We've talked a little bit about HEDIS in some of your other classes, but there are other quality indicators as well. And so those have to be factored in. Dictation systems. There are still some of those around. Some are embedded, such as in the radiology system with front-end voice recognition. There are also EHR systems that have front-end voice recognition systems to provide dictation services to physicians. like transcription systems, dictation systems are very much becoming a thing of the past. But again, it's important for you to know about those, so that's why we're going to touch on them. Computer-assisted coding, CAC systems. Yes, those are very common now, both on the inpatient and outpatient side of life. And then clinical documentation improvement, or CDI systems, where you're looking at the documentation as it's being generated at the point of care and using that to kind of anticipate what the coding will look like, to identify opportunities to clarify diagnoses and those types of things. All right, so what about that release of information disclosure management system? Release of information manages the processing of requests for PHI. The disclosure management system then tracks those disclosures for reporting purposes. If you think back to HIPAA and all of those rules that they have, one of those is disclosure management, that you have to keep track of all releases that are not for treatment, payment, and healthcare operations. However, most organizations have found it beneficial to track all disclosures, and so, or most disclosures, I should say, and so they include those in their disclosure management system. Disclosure is defined as the release, transfer, provision of access to, or divulging in any manner of information outside the healthcare facility holding the information. And again, you'll notice that disclosure does not say except for treatment, payment, and healthcare operations. It's any release, transfer, provision of care, even though organizations are permitted to not have to track and disclose the others. Again, from a management leadership perspective, you may want to think twice about having that as your policy. Release of information, staff and leaders can use the system to check on the status of requests, and the status of the request must be updated and kept current. So for instance, if there's a reason why there's a delay in the release occurring, maybe someone's having difficulty finding all of the information, or maybe you're waiting on an authorization to be returned, those types of things. Maybe there's a need for the request to be reviewed by risk management or legal counsel. Maybe you've got to have someone trek over to wherever old paper records or microfilm, microfiche are stored to obtain copies. Or other reasons. And so that all needs to be updated, because really you should be looking at any request that's older than 7 to 14 days to see what's going on with it, why is it still outstanding, what needs to happen next in the process. Some things that are captured, data elements that are captured, include patient name, health record number, patient type, date request received, type of requester, name of requester, name of contact at requester, address of requester, type of request. Is this insurance? For insurance purposes, is it a patient request? Is this an attorney request? Is it for patient care? Those types of things. Who was the ROI task assigned to, and what actions have been taken? The date actions were taken, the date the request was completed, and what exactly was sent. Were there any charges? And that brings up a whole another issue. Pardon me, I need to take a sip here. Sorry about that. We'll talk more about charges in the spring when we talk about legal aspects of health information management, but charges are not always a requirement, and I would go so far as to say there are very limited circumstances which you should charge for records. Just FYI. If you do charge, how much was charged, how much was paid, is there an amount that is still outstanding or due? And there needs to be a place for people to put free text comments about maybe they just talked to someone at the attorney firm and this was said or that was said, or so they're waiting on some additional information. It's important to have that for that. In terms of reports, you need to know the requests that have not been processed, the requests that have been processed but not completed, turnaround time of the requests, the revenue that was collected, and anything that's outstanding, which would be considered accounts receivable. Productivity by individual staff members, overall productivity, list of frequent requesters, and it's important to have multiple customized or customizable letters that you can pre-put into the system so that all you have to do is pull in who the requester is and it populates the name, the address, and that type of thing, and the request name and that sort of thing. And this goes into the customized letters, because sometimes you have to be able to notify the requester that there are no records of the patient that they've requested being treated at the healthcare facility or on the specific date that they are requesting. Unfortunately, if you get into charging, you have all the letters that go with, yes, you need to pay, here's the amount you need to pay, you've paid this much, but we still have this outstanding balance and all of that. And then there are letters that in the case where you are charging, there are times when you choose to have someone pay up front. Also, a lot of organizations have a cover letter, and that's good practice because in that cover letter, you can explain their responsibilities for protecting the PHI that you are releasing to them, that they cannot re-release it. So having a cover letter is always a good idea. Notify the requester that the authorization is invalid. There are lots of people who request information who do not have a right to it, and it's nice to have a pleasantly worded message that you can send back to them, letting them know that the authorization is invalid and why, and recommendations for next steps. And then there are times when you need to let the requester know that a patient authorization is needed. Just because they're an insurance company doesn't necessarily mean that they can have the records. If they are a life insurance company as opposed to a healthcare insurance company, it makes a difference. And so there are times when a patient authorization is needed, and that goes through that. Notify the requester when there will be a delay. Sometimes for whatever reason there is a delay. Maybe they've requested records that are 20 or 30 years old and it's going to take some time to track those down, get those copies, and get them back. That is not the same thing as going into an EHR, clicking a few buttons, and poof, within 5 minutes you can fulfill that request. So sometimes there is a delay and you need to let them know that you'll need to be working on that. Sometimes you need to send a letter letting the requester know that the records will be released as soon as the facility has had prepayment of copies. And again, this goes into the whole charge issue and the pros and cons with that. And then, of course, that includes generating invoices, because if you're releasing the records and then you want them to pay you for the records, you have to include an invoice and then reminder invoices if your payment is not received in a timely manner. And I'm just going to make one other comment about charging for medical records. I will admit I am not a fan of it. I have been on both sides of the debate. I have been there as a director who did charge. I have been there as a director who did not charge. I have been there as a patient, and I have been there as the person that has to face down patients and attorneys and others who are unhappy about it, about being charged or not being charged or being charged too much, or all of the different variations. And so I would just again remind those who are very eager to charge that sometimes the revenue you receive for release of information is very much offset by the hours and the frustration and the negative perceptions that are created by charging. So when you're looking at ROI systems, yes, they need to have all of these capabilities, but just because they have all the capabilities doesn't mean necessarily that you want to make the decision to utilize those capabilities. All right, functionality. You want to be able to monitor the efficiency of the ROI staff through a variety of management reports. You want to have information on various functions like turnaround times, productivity, backlogs, and then of course the revenue and accounts receivable if that's the direction you choose. Your reports need to include requests by employee, by requester type, by specific requester, or all requests. You want to be able to slice and dice the data. You want to have as many variables as possible that you can select when you want to select them. Most software systems have what are called canned reports that come with them. They're a series of reports that have been made up over time by the company based on customer requests, and that's what you get. The best systems then offer you the ability to pull information and either create your own reports or have someone in IT be able to take the variables you want and create a report for you. So just keep that in mind. Moving on to encoder and grouper. An encoder is that specialty software used by coders to select the appropriate code for the diagnoses and procedures supported by the health record. Encoders are used on the inpatient side, the outpatient side, and all of that. Encoders are different than computer-assisted coding. Computer-assisted coding, on the other hand, actually suggests the codes to you based on the documents that it has scanned and identified and pulled things from. In the encoder, you're the one who has to input the diagnoses and procedures and follow the paths and select the actual codes, rather than having it brought to you and you kind of evaluate it against the documentation and say, yeah, I agree with the CAC, or no, I disagree with the CAC. With the encoder, you have that control. You just put it in up front and go through all the steps, and that way you're sure at the end, yes, that's what I wanted, that's what I needed based on the documentation. So that's a really quick and sort of layman's terms for the difference between an encoder and a CAC. A grouper is software that uses the data elements to assign those codes in the encoder into it. It takes all the codes, diagnoses and procedure codes, and runs them through the software to then identify the appropriate MSDRG or APR-DRG or whatever type of grouper it's doing. And those are on the inpatient side. On the outpatient side, it looks at APCs and rolls those into appropriate APCs for billing. Encoders, there are types of encoders. One is rules-based, requires the coder to type in a name or portion of the diagnosis or procedure. That's the most common. And then it generates a list of suggestions from which you select. That's the old traditional 3M encoder right there. That's what they're describing. There's also an automated codebook encoder that lists those in alphabetic order like the index, and you can move through it that way. Most of us are taught the rules-based encoder. That's what most of us have been taught in the past. But there is the automated codebook encoder for those who like to pursue it in that direction. The most common groupers are the MSDRG grouper and the APC grouper. And then there's the APR-DRG grouper, and there are some other ones. And you always need the most current version of the grouper, but you also need the last couple of versions as well. And you need to make sure that your system has access to that. Because if something comes back to you from an insurance company or the government and you have to rerun it, you need to be able to rerun it through that other older grouper sometimes to be able to get it to where it needs to be. So be careful with it, with only saying, oh, I just need the current grouper. Well, the current grouper isn't usually released until, you're lucky if you can get it in September. A lot of times they'll release it at the end of September. It's supposed to go live the 1st of October, and by the time some hospitals and organizations, healthcare organizations, do all their testing and they sign off on it, you can be looking at the 2nd, 3rd, or 4th week in October, which creates a whole bunch of revenue and DNFB issues. But above beyond that, you want to make sure that you have not only the most current, but you have the one previous in case you need to do something different. And some insurers, including some Medicaid programs, have developed their own groupers for use. So you have to be aware of that. I think this next slide brings up a really big point that sometimes we don't always talk about clearly or openly, but just because you use an encoder doesn't mean that your code selection is going to be perfectly accurate. again, you're the one with this that you as the coder are hopefully reading the documentation very thoroughly and identifying the correct principal diagnosis and secondary diagnoses, including CCs and MCCs, and you're putting it into the system and you're watching how the encoder is moving it through and you're answering the questions correctly. Even the best encoder has areas of errors or issues that you have to know of and be aware of. And the same thing with CAC, computer assisted coding. Those are great, and they will look at the documentation and they will recommend a code to you. But if you don't know how they got to that code and you don't know that that code truly reflects what's in the documentation and what the physician was trying to communicate, it may not be correct. So again, you can't just say, oh, we use an encoder so I know it's accurate. That's not true, because we are human and we make errors, and sometimes and that's going to be reflected whether you're talking about an encoder or a CAC. But one of the biggest advantages in using an encoder rather than a book is that it does prompt you. It does have the rules built into it, and it walks you through it. But of course, you are all second-year students. You know this already because you've been having classes with Shelley Grant, and I am quite sure she has covered all this information with you, so I'm going to move on. Data elements that are needed for an encoder grouper system include diagnoses and all those different ones, procedures, age of patient, and their date of birth. I would say both, not one or the other. Discharge disposition. Oh yes, definitely. Think about those because that has a big impact. Gender, patient name, health record number, account number. And that's just the minimum that are needed. There's often other pieces of data that you want to include. A lot of times you need to include the surgeon, the physician, any consultants. You need to include, you know, if you're doing outpatient stuff, you may need to have where it's at, location codes, and things like that. So this is just basic, just very basic. All right, reporting. These systems typically don't have a whole lot of reporting. It's usually built out in other places, but back in the day, I did use a best of breed system that had some really awesome encoder reports. And they captured everything from coding productivity and tendency of using, frequency of used codes, and all sorts of other stuff that I could use. And it was great. So most EHRs that have encoder and grouper systems, they use one of the major players for that. They just drop it into their EHR. That's what you'll run across, unless they choose to do one of those best of breeds. And if they choose to do one of those best of breeds, you are so lucky. Lucky, lucky, lucky. Enjoy every moment of it, because it is so much easier to use than one of the EHRs where they've dropped something into it. But anyway, the encoder used to assign codes and MSDRGs using edits to assist the coder. That stuff is all transferred to the hospital financial system. IS may be able to run reports through the EHR for the MSDRGs and whatnot that are assigned. You'll be looking at MSDRG APC analysis reports. But again, if you have a really good system, a really awesome system, you'll be able to get productivity, accuracy, frequency, different types of, you know, time. How long does it take on average to code, and how many codes on average are involved, and different things like that. So hopefully you get one of those really cool systems. Cancer and other registries, that's a collection of information that's related to a specific disease, condition, or procedure. And it's really collected for analysis and comparison. Registries are sort of like a big database. They track, there's cancer, diabetes, trauma, transplant, implants, and And birth certificate registry is another type of a registry, although it's a little bit different than these. And so I think it's going to talk about it a little bit later in this slide presentation. Generally, they look for basic demographic information, reporting, treatment, description of condition. They sometimes track these patients long term. Some common data elements are patient name, health record number, dates of service, physician, date of birth, date of diagnosis. I would also include in here the diagnosis itself, any procedures that are done, things like that. And for, let me go back, and for instance, transplant registry, what was the organ or tissue that was transplanted? When was that transplant? When did it take place? What kind of medications were they given afterwards? Did they have any infections? Were there any recalls on the transplant, if it was like a tissue transplant or anything like that? So some of the registries can get very involved, and other ones can be very simple. But for instance, with cancer, they're looking at it long term. They're looking at the person's survival rate and when did they go into remission and what all types of treatments did they have during that time, chemo, radiation, what was their chemo regimen. There's a whole bunch of things that they capture, not just their staging and grading of their tumor. Yep, and here, cancer registry information, it's going to track it all about the patient's cancer from time of diagnosis to the time of their death. Site of cancer, type of cancer, treatment received, date of last contact, the TNM stage, tumor node metastasis stage. Were there any lymph nodes involved, and if so, how many? What's the behavior type of the cancer? What was the date of the patient's death, the grade of the neoplasm, size of the mass, physician name, accession number, all those types of things. And they're verified by the cancer registrar. And I want to stop here really quick and mention there is a joint program between AHIMA and the American College of Surgeons where you can become a certified cancer registrar by taking an online program. And I want to say it's 3 or 4 modules. Last I knew, I think it was 4 modules, maybe 3. Haven't looked at it in a while. But anyway, you can become a certified cancer registrar, and it's a joint program between AHIMA and the American College of Surgeons. And if you are at all interested in cancer registry, I would strongly recommend you pursue it. Because cancer registrars are in need and the number of cancer cases across the nation still is very high, and so they'll continue to be tracking these patients for a long term. Anyway, the program report is automatically generated, transmitted to a respective statewide cancer registry normally housed in the state's Department of Health. Okay, and let's see here. So there are management reports looking at productivity, reports on the contents of the registry. Some common reports that are usually pre-programmed include life expectancy, follow-up rate, list of patients due for follow-up, patients lost to follow-up, follow-up letters to patients and physicians. And then it goes on to trauma registry. That's tracking patients with traumatic injuries from initial trauma treatment to death. So say someone's in a very severe car accident and they have traumatic injuries, it's tracking those patients to see what happened to them and how did that work together, statistics about trauma. And you usually see trauma registries in major medical centers. Some things that they collect: site of injury, type of injury, how the injury occurred, date of injury, time of injury, is it work related or not, the codes that have to do with it, safety equipment, registry number, if they died, was an autopsy performed, and if so, what were the results, when did they arrive to an ED department, or were they life flighted from the accident site directly to a major medical center, to a trauma unit. Outcomes, follow-up rates, best practices for patient care, and you work with someone in IS to provide statistics on cause of injuries, types of injuries, other descriptive statistics. Chart locator system. This is also called a chart tracking system. It's designed to identify the current location of the paper medical record, although you could have this for your microphone microfiche and have sort of an electronic version of that in some places. It's important, especially if your records are housed off-site. That's really critical. And also, if there are little corners of your organization that are still keeping paper records after all this time, they have to have a chart locator system. Are they in order by patient number? Are they in order by patient name? How are they stored? And how can they be accessed by, say, the emergency room physician at 3 in the morning when that clinic or that site is closed, because they have to be accessible for patient care. So some things that are there are where the record is currently physically located, how long has it been in that location, when is the record due for return to the HIM department, when is the record overdue to be returned, and who checked it out. So data elements include patient name, health record number. Sometimes these paper records are so big you have multiple volumes. It's not uncommon to see somebody with 15 volumes back in the day when it was all paper charts. And then the location of the record is checked out to, date it was checked out, when it was returned, who checked it out, who checked it in. And management uses chart locator reporting to identify user requests, productivity tracking, identification of trends in terms of how often these records are being retrieved and by who, identification of areas in the healthcare facility where records are not being returned in a timely manner. Chart deficiency. All right, we have to have a chart deficiency system. We need to know what's incomplete in that record and what needs to be completed and who does it need to be completed by and how old is that completion. Think of those old verbal orders, those old handwritten verbal orders, or signatures on reports. I mean, there's still times when providers need to do an electronic signature on a report, and that would all be included in here. And heavens to Murgatroyd, we hope that they are not missing an H&P or missing a discharge summary at discharge and those types of things. So the documentation requirements need to be based on accreditation regs, state licensure requirements, federal rules, other standards and things that the healthcare organization is subject to. Specific documentation requirements should mandate when reports such as the H&P should be dictated or written. I would say discharge summary and operative reports are just as critical, as well as consultation reports. Although consultation reports are usually pretty good about being done because the consultants want to be paid for their time and they know that a report is required for that. You should also mandate what is in the content of those reports to make sure that they are complete and they have all of the elements that are required. And then the deadline by which the entire health record should be complete. Deficiencies can be paper, imaged, or EHR, depending on the information system. With imaged or electronic records, physician can complete from the office, home, or other location because it's all electronic. Paper records, they have to come and come to the designated area and sign. Now that's the way it used to be. Most paper records now are scanned and a deficiency is assigned electronically. It's very, 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 very rare that you have a physician coming to physically sign a piece of paper in most healthcare organizations. But it could still happen. So some common data elements that are captured by the chart completion system need to be patient name, health record number. I would also argue account number, discharge date, physician needing to complete the deficiency, what needs to be completed, the type of document, the type of deficiency, is there a date of surgery, comments, date the physician last worked on the records. You have to have the functionality of being able to track how the deficiencies age and you need to be able to generate lots of reports in case you are a facility that suspends physicians admitting privileges for delinquent health records. And you need to be able to see all of that, track all of that. If you suspend a physician, you need to know exactly when it happened and who was notified. And then when they've completed everything, that you've validated it, and then again, you've lifted the suspension, who you've notified, when you notified, how you notified, all of that. And then you monitor the volume of deficiencies by physician and service. And I would say not just physician and service, but by type, by type of activity, type of deficiency, all those types of things. The more information you can slice and dice for reports, the better off you are of being able to find what's causing your outliers and be able to attack those to really decrease your number of delinquent records. Birth certificate system. It has been ages, but back in the day I did do birth certificates. When I worked in Florida, I worked for a hospital where birth certificates were done by the HIM department, and that was me on occasional weekends, holidays, and days during the year. We had software that captured the information, and then we had the paper certificates that we printed out to and had to take them back to the mom and get signatures and whatnot. And birth certificates also included an affidavit of parentage and some other documents along the way. The content of birth certificates is established by the National Center for Health Statistics, but each state also has required twists on that. So you have to know, if you get into birth certificates, you have to know what your state specifically requires because it varies from state to state. At one point, I was asked to be involved with birth certificates in Indiana and in North Carolina, and those places also varied from Florida. So it was learning the rules for there and how they applied and what that looked like. And come to think of it, I did do birth certificates in North Carolina for a brief time. Or was that Indiana? I've forgotten now. I think that was North Carolina that I also worked on birth certificates. Been a while. Anyway, you collect data that's mandated by NCHS. You report that information. You allow your users to choose from the obstetrical physicians table, capture demographic information from the hospital information system. So you can see that there are interfaces that are coming from the EHR into the birth certificate system and pull data in. So let's say you have a new obstetrical physician. You need to make sure that they're in your EHR system before you try and pull them into your birth certificate system. They should be coming across that interface. You need to make sure that there are no omissions of required data before it's sent to the state. They do have mandatory fields and edit checks that help with that. And you submit the birth certificate data to the health department. And it's all done, it used to be done paper, where you actually had to envelope up the birth certificates and send them off, or you had someone that couried them over to the health department or the county building. So I've done both of those, but now a lot of that can take place electronically, where the information is simply uploaded. And then there's also a piece there when you do birth certificates that the parents can request a Social Security number and card be issued to the child. And so that request for the Social Security number goes through the birth certificate process and is submitted at that point, and then that goes to the Social Security Administration, and they take care of the actual issuing of the number and or card to the parents of the child or the mother. Usually it's the mother that determines all of it. A lot of times you're printing out data because you need to show it to the parents. They need to proof it, and thankfully a lot of times they will catch errors that you didn't notice. One of the things we found, and this was in North Carolina doing birth certificates, is that this was the way that we caught on to people who were in the country, undocumented, who were utilizing another person's insurance card. There were some immigrants, again, here without documents, government documents, and they were working and living in the county. And sometimes they would utilize someone else's identification and or insurance card to come in. And we did not know it at the time. The only way that we would find it out, because if we didn't have a photo ID to prove it or disprove it, or we couldn't do it with signatures because we didn't even suspect that it was happening, was in these birth cases where we put the information that they had registered under, the ID that they had registered onto the birth certificate, only to find out that really the mom that was in the bed was not the person that had registered or under the name that they had registered, and they wanted their real name on the child's birth certificate. And so you may find, if you're doing birth certificates, you may find that there are some twists that occur that you need to let risk management and legal know about. Obviously, if you have multiple patients who are using the same patient name and the same MPI record for care, it can really result in some serious issues. For instance, if someone says, "Oh yes, I'm Jane Smith," and they're really not, but Jane Smith is a diabetic, you may find that you're being given insulin you don't need because Jane Smith is in the EHR as being a diabetic. So there are some medical reasons why that is really a serious issue and why biometrics may end up being of help in certain situations, or really in all patient identification situations. But anyway, I digress. Going back to this. Information systems, you print it out, let the parents proof, make sure everything on there is perfectly accurate. You make sure that the system matches what has been proofed. You create a birth log. There is no paper log. Back in the day when I was in Florida, I had a paper log, but then it became electronic. You can use drop-down boxes to improve data consistency. There's edits to improve data quality. Again, those mandatory fields and required edits that are put in there across the country. And then you can allow the parents to order copies of birth certificates sometimes. Now that depends state to state. Some states will make it a part of the birth certificate process, others will not, and the parents will have to actually go and apply for a copy of the birth certificate separately. So again, you have to know your state and what your state will and won't do. You want your system to be able to generate statistical reports based on all those data elements that are captured, such as C-section rate or trending birth rates, key reporting capability. You want to make sure that you can report births to the state in the approved format. Nothing makes the state madder than you not using their approved and required format. They need the data coming into them electronically so that it will match with their system and move everything over smoothly so they can run their reports. The state may use, and often does, the birth certificate data that you report through birth certificates to feed other databases such as the immunization registry or to enhance tracking of childhood immunizations. That's how they can keep track of whether or not newborns have had their immunizations that they need to, and who to reach out to let them know that maybe they need these, then they haven't received them. So that is one way birth certificate data is used. Dictation transcription. Again, these are a lot rarer than they used to be. Back in the day, everything was dictated and transcribed. There was no front-end voice recognition. There was no back-end voice recognition. That has all come about over the years. Now we live in a very technical world where dictation and transcription are pretty minimal. They are built in a lot of times to EHRs, and the dictation is the voice capture with the front-end voice recognition that results in a finalized document that the dictator authenticates before they're done, or at the point of when they're finished with the report before they move on. There are still some dictation transcription systems out there for other reports, but again, that's becoming fewer and farther between. Dictation is used by the physicians to dictate various medical reports, and they're all listed up there, and there are even some that aren't listed that I would venture to say. It's the process of recording a provider's voice as he or she verbally describes a scenario, problem note, some other type of report that is recorded electronically. Then transcription is the process of deciphering the provider's recorded dictation and typing the medical document. The transcription system needs to be interfaced with the hospital's information system so it can pull down the patient's name, health record, their medical record number, their account number, the date of service, the physician's full title, name, service, all of those types of things. So you've got to have interfaces with the EHR for that. The key reporting focus for dictation systems, and I would also say transcription systems, is not only workload but productivity and that type of thing. You want to be able to track the volume of work that's being dictated, the volume of work that's being transcribed, what needs to be transcribed. Did providers leave blanks? Did a report get cut off? Were there other issues like that? And then the information can be used to determine transcription staffing levels, over time workload justifications, trends and patterns in dictation usage. An expander. An expander allows transcriptionists to type acronyms such as CHF, and the full phrase congestive heart failure will automatically be spelled out. When you're building or getting a transcription system installed, you want to make sure that your expanders are all pre-programmed, and as well as allowing transcriptionists to add their own to the expander. You want to have the flexibility of both. A lot of times what we did when we were doing a dictation transcription system conversion is we had the transcriptionists identify, or we copied their current expanders and pasted those into the system, so they had all of those in the new system. And if we couldn't copy and paste, we had them actually write them down and then pre-program them into the new system before the new system went up. So make sure that you do that. That's saving keystrokes and time, and usually it can be controlled by the healthcare organization. But you want it to be, you want some standard ones like CHF, but you also want the transcriptionist to be able to create her own expander so that it's comfortable to her and what she is doing for her productivity. And I don't know if it doesn't look like it's going to cover normals here, so I'm going to talk about normals for a minute because that is sort of the precursor to the cut and paste debate. Sorry, I needed another sip there. Okay, so the normals. Normals are what a physician can request, and it's typically done for operative reports. Surgeons typically perform the same procedures over and over and over and over again, and they follow the same steps every time. There are some twists to that, but back in the day when dictation and transcription were big, a lot of them used normals. They had what was their normal cholecystectomy, their normal C-section, their normal liver biopsy, their normal, I don't know, whatever procedure that they did. There, might have even had a normal for a heart stent. Anyway, that verbiage was placed, it was sort of a file that was kept that the transcriptionist could use as an expander, that when they went into the report, they could essentially click on Dr. Smith's C-section normal, and it would populate the report with all of the usuals that Dr. Smith, the steps he went through and the things that he did. And then the transcriptionist would listen to the dictation, and Dr. Smith would say, and there was this change and this change and this change, and here is the rest of the detail. And so the doctor would give you the pre-op and post-op diagnoses, whatever specimens were taken out, and all those types of things. It would give you the things that were specific to that individual procedure, but unless the steps changed, they usually didn't touch that portion of it. And so that became the precursor to the cut and paste, where the doctor did the same things, and so they essentially had that to begin from with the next report. Hopefully I haven't totally confused you. So that was normals. They aren't used hardly at all anymore. And like I said, unfortunately, they have morphed into copy and paste, which has brought a whole slew of problems, which if you haven't talked about those in first year, you will in second year. So we will talk about those again later. Transcription software products are designed to work seamlessly with dictation systems and voice recognition systems. They try to promote efficiency in the entire process, and they're designed for transcriptionists to work from home. They need to be able to track productivity because transcriptionists are almost always paid based on their line counts. I have been responsible for in-house transcription over my career, outsourced transcription, and a little bit of both. I've been responsible for all organizational transcription as well as HIM transcription, as well as overseeing radiology transcription. So I've had all of those types of things in the past. And they're pretty much the same. You approach them from the same perspective. You're looking at productivity, you're looking at accuracy, you're looking at quality, turnaround time, functionality, all of those things. There are incentive pay, bonuses, and rewards. You can establish criteria for those, and you monitor overall volume by report type to help identify trends and needs. It was very interesting when I was responsible for dictation and transcription. We would look at line counts by physician to see, on average, we particularly looked at very short operative reports, and we looked at very long operative reports. Those were outliers, and they helped us understand if all of our long op reports were done by 1 or 2 surgeons. We looked at those and looked for ways that we could find more efficiencies. If we had really short op reports, we were looking at those from a quality standpoint. Does this contain all of the required elements that need to be in an op report? And if not, we had to approach the surgeon and talk to them about, you're not telling us estimated blood loss. If they didn't have any, put none, but we have to have estimated blood loss addressed and things like that. So you can do that with dictation transcription. Healthcare quality indicators, that's really abstracting. It's a nice, I don't know, nice title for it, sort of like HIM instead of medical records. Abstracting is all about gathering information and providing it for I guess I should use their definition, shouldn't I? Sorry, I won't give you mine. I'll go with theirs. It's the process of extracting information from a document or data elements from a database to create a brief summary of the patient's illness, treatment, outcome, and entering summary into an automated system. Okay, that's a lot of words for saying basically there are different pieces of information that you need to gather when you're coding, and you need to put them in so that reports can be run off of them. That's pretty much it. A quality indicator is a standard against which actual care may be measured to identify a level of performance for that standard. Think about the HEDIS measures and how they're doing that. Back in the day, abstracting could be anything from the surgeon's name and the procedure, and it could be the number of weeks the pregnancy was. It could be whether or not an autopsy was done. It could be the names of all the consultants on the case. It could be whether or not the patient was on a vent and how many days they were on, how many days or hours they were on a vent. Different things like that were captured back in the day of abstracting. Now, there's very few things for the coder to abstract because the data is being captured in different places as it's occurring, and a lot of it's coming through the surgery system or maybe the respiratory system, respiratory therapy system. Like the vent is actually giving the number of hours that the patient's on a vent and those types of things. So it's no longer something that a coder would have to capture. However, going back to quality indicators that we may or may not capture in the HIM field, sometimes they look at facility infection rate, although I would argue that in this day and age, that is all captured out of infection prevention, infection control, because they pull our data. They look at, if we code a urinary tract infection, you can be sure that the infection preventionist is already looking at each one of those cases and telling us, oh, well, that doesn't meet my criteria, and that doesn't meet this criteria, or this should be done differently, or what have you. So just FYI on that. Number of deaths by physician, blood incompatibility. The blood incompatibility, that's captured all through the lab. That, unless that actually happens and it's coded by the coder, that's all being captured by the lab. Surgical errors, maternal deaths, outcomes. Yes, that does come from coded data. However, having worked in quality management, I also know that those go through quality management. Quality management is looking at those, and sometimes quality management contacts medical records or HIM and says, hey, this was coded like this, but it really doesn't meet the definition, or it's not accurate. You need to rethink the coding on this. I myself have done that sitting in a quality management chair for a healthcare organization. So just saying. Computer assisted coding, we kind of talked about this earlier, that's where the computer itself is going through your reports, it's picking up diagnoses and procedures, and it's putting them through their system, their artificial intelligence system, and generating codes. And then what the coder does is come into the CAC system, look at the documentation, look at the codes, and say, yes, I agree, or no, I don't. It's really the same thing behind having a transcriptionist go back in after a provider has done their dictation and done front-end recognition. Some places will still have a transcriptionist go in, listen to the voice, and make sure that there are no edits or changes or messages back to the dictating provider that need to be changed. And that's really what CAC is. It turns coders from coders into more coding analysts, where they're actually looking at the information and looking what the CAC has done, agreeing, disagreeing, identifying areas of that might need a coding query or what have you, and moving it on from there. They're not doing the easy stuff, so to speak. Computer-assisted coding, CAC systems use natural language processing, and we'll talk about that if we haven't already. What that is, to analyze clinical data to identify diagnoses and procedures, assign the appropriate codes. And NLP, it goes in here. It's basically taking human language and putting it into data that can then be manipulated by the IS, the information system. CAC systems do generate productivity reports, and they look at the number of records where the codes were changed from what the software originally recommended. They have some that they recommend you evaluate quality, accuracy, and completeness of the codes. And then they do sometimes do evaluations or reviews that are combined with financial information to talk about what opportunities are available or what the impact was on reimbursement claims and revenue cycle functions. But those are more of the high-end CAC systems that have lots of bells and whistles. And those are the ones that are more interfaced and more robust, shall we say. Clinical documentation improvement. I've been involved with this as well and have actually done it myself. So I'm very familiar with it as well, and the systems that work with it. I have used at least 2 different CDI systems in my career. They are where you go in, you look at the documentation. You may even be able to look at or run some preliminary codes through, sort of like an encoder, and then it'll identify opportunities for you or things to look at. Make suggestions, ask questions, those types of things. It identifies ways to improve clinical documentation in the health record, which ultimately impacts coding and improves coding and reimbursement. So that's what this is all about. It's really trying to catch providers as they are doing their documentation, as they are caring for the patient, to get the clarifications that are needed for very clear and easy coding on the back end and optimal reimbursement ultimately. Catching those MCCs, CCs, those types of things, and getting providers to move from talking about symptoms to diagnoses. All right, that is it for computer systems and HIM. That took a lot longer than I expected. I'm sorry for going off topic and rabbit trailing a couple of times, but hopefully the information was interesting and or helpful, and we did cover a lot. So I will be back next week, which will be week 7, and I will talk to you about administrative information systems. Take care. Have a great week. Talk to you again soon. Bye.